to be here tonight. I believe this is going to be my last case sharing with you folks, and I just want to say thank you. It's been a really fun educational opportunity for myself as well. So thank you for hosting me over the last year. I think it's been a tremendous asset and a lot of fun on my end. So we're going to share one more case with you.
Thank you, Tim.
And this is I think a fascinating case that highlights a lot of the uncertainty of what we do in interventional. With a bit of some twists and turns. It's a gentleman who came to us, was 50 years old, was known to have really zero past medical history, was an otherwise healthy gentleman. And in fact, he was out playing basketball with his friends. He was engaged in this adult basketball league. So once a week, he would go play kind of a full court basketball game with some of his friends, and did that weekly, and had always felt without any cardiopulmonary limitations. On the day of the event, he felt just generally unwell. He didn't feel like he was able to keep up, with his friends or his peers that day. Was just feeling generally unwell and off. He stopped about halfway through the game. He continued to watch his friends play the remainder of the game. He ended up going home, calling his wife for a ride, because again, he just didn't feel quite right. Once he arrived home, he was in the shower, and his wife heard a big thud, and he had collapsed. She immediately, came to his side. He was unresponsive, was found to be pulseless, and so she immediately began bystander CPR. And at the same time, there's another family member in the home who was able to call 911. She continued CPR in the bathroom until the first person to arrive was one of our police officers who took over CPR, was performing chest compressions. Until
Slides. Can I see your slide?
Your screen.
Your screen.
What's that? I'm sorry.
I lost your slides.
Oh, goodness.
Share again, Tim. Okay, they're back.
That going okay there?
Yes.
Yep, all back.
So, at this point, EMS had arrived, and they took over ACLS. They applied a defibrillator that showed in a wide complex tachycardia. We unfortunately don't have that strip, but it was a shockable rhythm, and they defibrillated him. He regained pulses, had never regained consciousness, and at that time was intubated in the field for a poor GCS, effectively. After intubation, he was noted to be making some appearingly purposeful movements and was biting at the ET tube, which did have some functional neurologic examination, but was intubated and transferred to our facility for evaluation of this ECG, which, as you can see here, was a sinus tachycardia with marked ST elevations, really V2 all the way out to V6 with some reciprocal changes as well. So he was activated as a STEMI from the field, was immediately brought into our cath lab in an emergent setting. On arrival to our cath lab, his blood pressure initially was 109/70. He was noted to be in a sinus rhythm with a rate of 75 with runs of NSVT and VT, for which the EMS had initiated him on lidocaine. He was also on a phenylephrine infusion at 0.06, a fairly low dose. He was spontaneously breathing at a rate of 18. He was
Why phenylephrine, Tim?
What's that, sir?
Why phenylephrine? Unusual agent.
I believe it's mostly because of the shelf stability, that it's easily readily available by the EMS crew. I don't think that there was a good physiologic.
Wasn't in our emergency room.
No, he did come in on the phenylephrine drip. He was on 50% FiO2, relatively low oxygenation needs. He was given aspirin 324 by the NG tube was placed en route. He was given 4,000 units of IV heparin. In addition, he was given 600 milligrams of clopidogrel per that NG tube that was placed. And then again, he was started on the lidocaine and phenylephrine infusions. some of this would not be a typical EMS intervention in NG tube and clopidogrel. He had made a brief stop in an outside hospital emergency room because of our EMS STEMI response system had triggered him to go to that hospital because it was physically closer. Unfortunately, their cath lab was on divert. So he had made a brief stop at an outside emergency room prior. So some of these were kind of more advanced interventions that typically. So this was the package that he had come in on in his hemodynamics at time of presentation. So he came to the cath lab in an emergent setting. We began the case with right radial access, placed the 6 French sheath in the right radial, started with a 5 French JR4 catheter, thinking that this was going to be a LAD or possible circumflex culprit.
Tim, can
Yes,
you
sir.
tell us about your thoughts on access in this case?
Yeah. So I think, our lab as a whole is strongly radial in nature, and that's just given the safety and the efficacy outcomes that have been demonstrated in a number of trials. I think, pertinent to this is I believe it's the rival trial that was at RCT comparing radial versus femoral access in the setting of STEMI that showed a small but a statistically significant mortality benefit when radial is used. That's typically our default, and we're successful in greater than 95% of cases. I think the times I would deviate from that are if I have a strong pretest probability for a need for mechanical support, or if the patient's hemodynamics are such that I think upfront hemodynamic support is needed. Those are the times that I'd at least consider going femoral. But by and large, radial would be.
Yeah, I think that's, spot on. I mean, certainly we believe and look out for a performance metric document that will come out in a couple of weeks, somewhere 2 to 6 weeks on performance measures. But radial access in the setting of STEMI is associated with a mortality reduction. And so you can imagine what the new performance metrics might look like, given the statement I made. And then the second is, in terms of what you believe the need is for MCS, and whether you think you're going to need it and put something in the femoral artery just in case, or go femoral artery and then add your impella or what have you, and then do it all through the impella. So you felt he was warm and perfused, and you had the time to start radially.
Yeah.
Okay.
That was our assessment at the time. Our initial angiogram images on the right, so again with just a diagnostic JR4 catheter, demonstrate a mild amount of plaque, really kind of, to me, 2 flow in those very distal vessels, although there's really no occlusive etiology there. It's kind of a slow flow throughout those 4 putting superior, inferior, PDA, and PL respectively. So did not identify a culprit on the right. No collaterals, no significant angiographically apparent collaterals, at least feeding any system on the left. So we returned again anticipating an anterior event with the guide. So we exchanged our diagnostic for an EBU4 guide. We used the 375 up front just based on the patient's height, and that was found to be short. This is our first picture here. So you can see what appears to be an acute thrombotic occlusion of a at least moderate to large caliber LAD without any significant collaterals feeding that territory, and a circumflex with the branching OM, again without much as far as obstructive coronary disease goes, but certainly some plaque. You can see a little bit of antegrade penetration into that thrombotic occlusion. We were fairly quickly able to get, this is our run-through wire, which is our typical workhorse in most settings, down to the distal LAD. We began with ballooning with a 2.5 millimeter semi-compliant balloon, which was able to reestablish flow in the vessel. And at this point, we could confirm wire position in the true distal LAD. We could, analyze and interpret the diagonals as well. There's this very large caliber diagonal which has some very mild disease at the proximal vessel, but otherwise is unaffected. There's a similar branching diagonal just proximal to that as well, which was relatively free of disease at the ostium, and then identify better the culprit size and where we want to start to plan our intervention, both the proximal and distal landing zones. But able to reestablish flow.
So what would people do next before you show the next picture? What would be the next reasonable thing to do here or not do here? Any thoughts?
วิดีโอเมสเชิญเลยค่ะ please comment อาจารย์มนูน any thought from you อาจารย์วัฒนยูคะ
It's a quiet group this morning.
based upon election result I'm joking อาจารย์น้ำหลัก
Understood.
อาจารย์เกรียงไกร
Yeah, I think this is a straightforward case. You have demonstrated that there is no need for thrombus aspiration first, just do small balloon opening, and you can see that the thrombus grade is quite low. In thrombus grade, it's just only thrombus 2 or 2 or 3, with some disease in osteodiagonal. You may put a protect wire into diagonal branch. That seems to be big, but there is two diagonal branch originate from the rupture plaque lesion. This is straightforward. And for the initial angiogram, when you do the 5 French diagnostic catheter, the LAD caliber is quite large. I see from angiogram is at double or triple size of the diagnostic catheter, the first image. So the diameter of the LAD should be around 4 or bigger than 4. So in this case, if we have to implant the stent, we have to consider a rather big stent and do the proximal optimization of the proximal half. And the distal half is a little bit smaller as usual.
So I agree with all of that. And what I'd say is, and I will tell you, I've not seen what happens next, or if I have, I forgot. But things are straightforward till this moment. And something about the history and the initial angiogram makes me concerned that the left ventricular diastolic pressure is elevated, and that there is a high plaque burden behind what we see angiographically that is full of lipid-rich nastiness, and that placing a stent and extruding some of that nastiness may result in no reflow. So I would IVUS next, and if there was a big necrotic nasty lesion in there, I actually might put a microcatheter down and pre-treat the very distal vessel, because I really worry about no reflow here.
Yeah.
So that's my prediction for what the weather pattern looks like, and I think we're going to encounter some turbulence.
Yeah.
Yeah, I agree that this is a high plaque burden case with maybe red thrombus, maybe a large lipid pool. In US, do you have a mesh stent? Mesh stent, M stent, we call M stent. It is the stent with the small mesh, the layer inside the stent. We use that to prevent the squeeze cheese appearance when we do ballooning.
I knew there was a reason I don't like Swiss cheese.
So
Thank you for those comments.
Yeah. Thank you. So we moved forward with some additional balloon dilation, prior to which we did give some intracoronary nitroprusside, because similarly, we did see kind of slow flow, and most of the side branches. We were concerned, you even saw that on the right, those PLs and PDAs. And similarly here in this diagonal, you can see the dye does stick around for quite some time. So we gave some intracoronary vasodilators, and then we went to balloon further. We used a 3 NC balloon to further pre-dilate the lesion. Balloons seem to yield or fully expand, and the lesion readily yielded. We did not IVUS in this case. We then brought in, on the basis of our best guess in relation to the guide, as you guys had suggested, a 3.0 by 26 Resolute Onyx Frontier stent. Taking it just slightly beyond both of those diagonals, we felt relatively confident that those diagonals would stay patent despite the presence of the diseased proximal segments. And the 3.0/26 stent was then deployed with full and symmetric expansion here.
Tim, may I ask you about the Frontier, because we don't have in Thailand, and I heard that Frontier is FDA approved for bifurcation. Can you explain that to us? It is very new for us also.
Yeah, the Frontier platform, I can't speak to depth about the approval for bifurcation outside of I acknowledge and know that it is, but the thing that we've noticed is probably the deliverability is a little bit more favorable as compared to the Resolute Onyx generation of stents. They come in similar dimensions and lengths, but the deliverability profile seems to be slightly more favorable. Is kind of the day-to-day technical difference that we've noticed.
Yeah, and the approval process for it really comes out of the fact that they had in the clinical trial left main bifurcation stenting as a subset of the patients, and it proved to be acutely safe and effective without any excess hazards. So that's the main reason, and under the subset of complex PCI.
Once the stent was deployed, we knew it was a bit undersized in relation to the diameter of the vessel, so we post-dilated initially with the 3.0 millimeter NC balloon, followed by a 3.5 millimeter along the whole length of the stent, and subsequently with a 4.0 millimeter NC balloon just along the proximal segment. You can see here's our completion angiography showing reasonable, TIMI3 outflow in the vessel, no proximal or distal edge dissection, and persistent flow within those two diagonal vessels. So we're fairly pleased with the angiographic appearance of the intervention, albeit we did not do intravascular imaging in this case.
The one other comment I'd make on the stent, it's a single wire technique with more rounded surfaces, and it's quite conformable. So those are the attributes, that they stated were reasons why they felt it would be good for bifurcation stenting over others. But it's not specifically designed to do bifurcation stenting in terms of access and being able to go into both branch vessels concurrently. You still have to create the neointima and then deal with the side branch with the second stent should you have to stent the side branch.
Yeah, to an extension of that, it has a very favorable expansion profile as well. With the 3.0, you can bring it up to a 4.5 millimeter dimension, so it does have significant expansion capabilities with those kind of lower profile stents. So at this time, he remained hemodynamically stable. Blood pressure again was approximately 110 over 60. He was in normal sinus rhythm with rates in the 70s to 80s. You know, we had recognized he had a large anterior infarct VT arrest, so we opted to leave in PA catheter. I'll show you the numbers. And then at the same time, you know, he was intubated but had ET tube, and we had fluoroed the NG tube that was placed outside and found that it was coiled in the back of the mouth. And so we were, you know, uncertain if he had actually received his clopidogrel dose orally. So we put in a PA catheter from the right IJ. I'll show you the waveforms and pressures here. And then we also started him on Cangrelor, which is one of our newly approved, very short-acting intravenous P2Y12 agents. And so it starts with a bolus and then a drip with a onset of action of approximately 3 minutes and a very short half-life as well. So this is a medication that we've been going to more readily due to its favorable pharmacokinetics, especially in people without oral access. Especially there's some data in cardiogenic shock with delayed absorption, you know, of our typical oral agents that this may be a preferred strategy, and that's what we implemented here.
You mentioned Cangrelor. What about the aspirin? I mean, 10 years ago we do have SPG intravenous form, the 1 gram intravenous instead of putting aspirin per oral or per rectal suppository. Do you have SPG in US?
We don't.
No.
No, we're.
And second question to Dr. Sikarua, because you start the conversation about the nasty lesion with a high risk of no reflow. What is the real strategy that we should perform in my thought? In acute MI PCI, it is something like a river of no return. Like when Marilyn Monroe, she sang this song, River of No Return, and you feel something and then you cannot take it back. So the issue that I want to ask is to do the performing the distal embolization protection device in this case. I know the study does not support, but in some case with nasty lesion, with a thrombus in situ that they may have no flow or no reflow. Will you consider the distal protection device? And Tim, do you give a nitroprusside because you think that nitroprusside could prevent the no reflow? What about the distal protection device?
Yeah, so I think, you know, that's a really great question. And a couple of things about it. I think in this case, I'm worried about no reflow for 2 reasons. One, it's my belief that the left ventricular diastolic pressure is elevated and there's a tremendous amount of myocardial edema. 2, I imagine there are metabolic disturbances from the period of CPR and that the person probably has an elevated lactate, and the combination of those 2 are impairing the microcirculation independent of the thrombus burden and the plaque. So a couple of things I would do. So 1, reestablish flow as was done with a small balloon. 2, pause and give vasodilators, potentially including nitroprusside distally if you know, there continues to be TIMI2 flow to make sure that one delivers it. 3, IVUS, 4 IVUS, 5 IVUS, 6 IVUS, or OCT to better understand the amount of lipid-rich pore that's behind there. In a different period of my life, I did use a lot of embolic protection during the anterior infarcts, where I had lipid-rich core, and it still seemed like I didn't have any reduction in the occurrence of no reflow. But what I did notice is that when I would place the stent, that whenever I went high pressure, I seemed to Swiss cheese and embolize that lipid-rich gruel that was not caught by the embolic protection device and incur no reflow. So there are times where I will reestablish antegrade flow and stent, demonstrate that we have overall reasonable strut apposition, and come back another day and finish and not be impatient and experience that no reflow. There was a great case presented at Sky on Friday that demonstrated repetitive RCA no reflow in the occurrence of shock because the group didn't give enough time in between, and they went hot. Would have waited a few days and brought them back. But that's a very uncommon approach. But I think that this person is likely, at risk of that.
So proceeding through the case, we did place our PA catheter. The hemodynamics were, as I'll mention here, right atrial pressure of 12, RV of 42 over 12, PA pressure of 41 over 20 with a mean of 28, and a wedge of 17. PA saturation was 61% with a hemoglobin of 15.7. So our thick cardiac output was 4 liters per minute with a cardiac index of 1.6. He was a very large gentleman. He was about 6'6" and 100 kilos. So a very large PSA. But you can see his index is 1.64, and then his hemodynamics during the case are kind of highlighted over here. Mainly these black lines were his systemic pressures on our anesthesia monitor during the case. And so his blood pressures throughout were, ended the case pressure approximately 120, over 75 or so, being on a small dose of norepinephrine, 0.06 micrograms per kilo. So, maybe I'll pose it to the group. We had given him 40 milligrams of IV furosemide after performance of the right heart cath. And then what would the group do next in this gentleman based on these hemodynamics? Would anybody consider mechanical support at this time or continued monitoring in the ICU?
Ajahn Genkai, you want to comment?
I think everything is okay, stable with only low dose of vasopressor duct. So I think we can move to the CCU for monitor, not used for the intravenous pump. But I would like to know about the echo findings in this case because he has a large infarct. So sometimes it's complicated with the MR or VSD. You can show me the result of echo in this case.
Yeah, we will have an echo here shortly, but we didn't have one to this point.
Is SVR calculated at what, Tim?
Oh, I'd have to do that off the top of my head here. I mean, his map was, we're going to call it 75-80, with a cardiac output of 4. So he's elevated SVR for certain. I'd have to calculate it.
And lactate?
Didn't have a lactate at this point, but shortly thereafter, it was about 1.6.
Yeah, I don't think I would escalate to a balloon pump or a Impella at this point. Those are invasive blood pressures or non-invasive?
Invasive, yeah.
Yeah, I myself would likely continue to watch him, especially if he felt warm and the lactate, was under 2. Wedge is 17. mild pulmonary hypertension. I don't feel compelled to put a device in him at the moment.
Yeah, agreed. That's what we did in this case. Okay.
Yeah, would anybody put a device in him?
Ajahn Namrat.
Yeah, agree. There's no room for balloon pump at this moment.
We took the same approach. So we placed our PA catheter. We evaluated his hemodynamics. We gave him 40 of Lasix and felt he was most appropriate, best treated in our cardiac ICU. So he was quickly transferred up to our ICU. There we got some baseline labs that showed a normal creatinine.
Just one thing I would say, I think that's completely reasonable. Tim Henry might say this is a perfect case for a balloon pump. Low index, not stage C or stage D, not crashing.
Yeah.
And he certainly presented registry and single center data on it that makes everybody feel better. So I just throw that in there.
Yeah, I think that would have been a very reasonable approach here as well. Yeah, so we did get a lactate shortly after landing up in the cardiac ICU. It was 1.6. He had very mild AST, ALT abnormalities, and otherwise was fairly unnotable baseline labs. Shortly after arriving to the ICU, over the course of about 2 hours, he had further hemodynamic decompensation. And so we finished the case at about 3 that morning, give or take. He had arrived upstairs. His initially blood pressures, this pink line are his systolics, and the lower are his diastolics. You can see we're 120 to 130. And by 5:30, 6 o'clock in the morning, he had become increasingly hypotensive. His blood pressures were now 90 over 60, dropping pulse pressure, not much of a compensation in his heart rate. He remained normal sinus in the 70s to 80s. We reshot numbers off the PA catheter, and his cardiac index had decreased to 3, or his output had decreased to 3.2, index of 1.3, extremely elevated SVR, and a lactate of 2.9 at this point. So over the course of really just 2 hours, had marked hemodynamic and subsequent metabolic derangements and decompensation. So at this point, we opted to bring him back to the cath lab, anticipating the need for mechanical circulatory support. So in this instance, given we had anticipated he was likely going to need a pump, we had gone through the right groin, so we went to the right femoral artery. This is our scalp shot through a micro sheath. We placed the 6 French sheath in the right femoral, and then we immediately went up with a 5 French JL4 diagnostic catheter. Just given he had such clinical change over the course of a couple of hours, wanted to re-demonstrate patency of the previously placed stent, especially given he had not received his Plavix, etc. And the stent proved to be, patent in nature. You can see just the marked vasoconstriction and really all the vasculature. At this point, he was on increasing dose of multiple pressors. He had been started on epinephrine in addition to his norepinephrine and some vasopressin as well. We, after confirming, patency, we placed our Impella. We do this in a pre-closed fashion. So after our 6 French sheath is removed over the wire, we place 2 per-closed sutures in a 10 o'clock and 2 o'clock position. Those are deployed. The 14 French Impella peel-away sheath is then placed, and then the repositioning sheath is placed, and those per-closed devices are so we were successful in getting the Impella in fairly short order. And he had good flows. He was flowing at approximately 2.8 liters a minute. This was an Impella CP. And we were concerned he was a bit undersupported. And so you can see here, again, this is his hemodynamics from the time in the cath lab, that he had was quite hypotensive with a poor pulse pressure upon arrival. So now the green is his arterial, so he was about 100 over 75, give or take, was his systolic pressures. He was on increasing doses norepinephrine now at 0.1. He had received vasopressin pushes as well as a vasopressor, and he continued on the cangrelor and the lidocaine drips for the NSVT. And so we, at this point, had monitored him for approximately 20 minutes after the Impella had placed. We reshot his numbers. You can see here that his CPP did not change much. His PA pressures did come down somewhat, suggesting that he was being somewhat effectively unloaded. You can see the red line here, or his pulmonary artery pressures. You can see both the decrease in the systolic, the PASP, as well as the PA diastolic, suggestive that his LV was being effectively unloaded, but he remained, quite hypotensive, extremely clamped down, and his lactate had continued to increase. And so over a period of about 30 minutes, we put the Impella in and we just kept him in our cath lab for hemodynamic assessment, really. And at this time, we felt he was under supported, and so we activated our shock team, which consists of an on-call interventional cardiologist, our advanced heart failure and transplant folks, our cardiac surgeons, and then our critical care ICU docs, to have a case-by-case discussion about further escalation of mechanical circulatory support. And this approach has been demonstrated in the EIS and some systemic nationwide shock registries to be an effective strategy at decreasing mortality in the care of patients with cardiogenic shock. And so that's our process here. I'd maybe query you, what are you guys doing at your hospital with these acutely sick shock patients?
When you mentioned about the initial cardiac output during the PCI, you mentioned that the cardiac output is 4.03. It's fixed method. What about the thermodilution method? And what's about the follow-up cardiac output that decreased from 4 to 3? Is it thermodilution or again fixed method?
They were FIC. Yeah, all three of those were FIC. We did not perform thermodilution in the cath lab the first time. We do perform thermodilution in our cardiac ICU, but I believe both of these were by FIC, derived by FIC, using the same assumed VO2. We certainly don't know if someone who's had a cardiogenic shock and arrest and is intubated, but the VO2 presumption was consistent at least.
And the BMI you told me was what, Tim?
His BMI was I believe in the high 20s, but his BSA, he was 6'6", 220 pounds. He was a very large gentleman, but not in a sense of overweight. He was just a very large gentleman.
It's always a challenge when you have somebody of that stature, because none of the data was validated for people of that height. And then we know that, and we actually did the study and got published in CIRC, the wide range of assumed FIC and the impact on cardiac output for obese individuals.
So we were concerned enough with the clinical picture, the continued deterioration, despite what we had thought was effective LV unloading, that he was under-supported on the Impella. And so, we moved, after our discussion, with our multidisciplinary team, we moved to cannulate him for VA ECMO in the cath lab. And so our ECMO team is comprised of a multidisciplinary group of critical care, intensivists, cardiac surgery, interventional cardiology, structural heart team. And so, we had, after activating the shock team, they activated the ECMO team, which brings in the perfusionist, the cardiac surgeon who works with us closely on our ECMO team as well. And then we began the cannulation in the cath lab. We placed a 5 French, using all micropuncture, ultrasound, fluoroscopic landmarks, a sheath in the left femoral vein, a left femoral artery sheath. These were just 5 to 6 French, And then we did a distal perfusion catheter as well. I'll show you what that entails, but we placed a 6 French braided sheath in the left SFA in a kind of an antegrade fashion. We then, with our cardiac surgeon scrubbed with us as well, we dilated all these, ultimately placed a 25 French, this is a multi-return venous sheath up into the IVC, placed a 21 French arterial sheath in the left common femoral, and then that distal perfusion catheter, we take actually the off of the arterial return, there's a side arm, and we take that and redirect, and with the male-to-male connector, we attach that to our sheath that we placed in the SFA in an antegrade fashion. So this is ultimately what it looks like. This is the return cannula from the VA ECMO, so it's a pressurized system, and there's enough pressure coming off of the side port to feed through an extension tubing through a male-to-male connector the 6 French braided sheath that we had placed in the SFA. And so this maintains antegrade perfusion to the limb in the situation, or sometimes the expected situation, that this very large arterial cannula is going to occlude the common femoral artery. And so you worry about distal ischemia, compartment syndrome, need for interventions there. And this has been demonstrated in some observational studies, at least, to decrease the risk of limb complications related to VA ECMO. So this was our strategy in this case. We had the Impella in already via the contralateral groin, the right common, and so we used that to support a venting strategy. And so rather than trying to provide a significant cardiac output, we were initially at about 2.8 liters per minute of hemodynamic support. We intentionally turned it down to P2, the lowest level on our Impella, just to provide what we call LV venting. And so we know when you're on VA ECMO, there's retrograde filling of the aorta. There's some of that potential drawback or potential retrograde flow into the LV. Without any action, if there is significant pullback into the LV can become further distended. You have increased wall tension, decreased coronary perfusion pressure, and then you can get secondary pulmonary edema and congestion as well. And so by employing one of these venting strategies, we already had our Impella in place, so it's quite easy to do. The hope is to avoid that kind of cycle of backflow into the LV, increase your coronary perfusion pressure, maintain reasonable geometry of your LV and venting, and avoidance of pulmonary edema. So we used our previously placed Impella for a venting strategy in this instance. To do it, some people have to do that with a balloon pump. The Impella is an increasingly employed strategy, or there's a left atrial cannulas that can be used to directly unload the left atrium as well.
I think in this physiology, obviously, unloading to deal with the impact of an elevated SVR due to the retrograde is essential. And how much you need, Impella versus the ECPella strategy, one could debate.
So at this point, we were able to get some echo imaging. So this was after he had been across the aortic valve, slightly into the lateral wall, but free of the valve. And you can see really, marked LV systolic dysfunction. At times, really minimal contraction of the left ventricle. And these are pretty, difficult images, as you can see here, but had really acute stunning of most of his LV function. He was then transferred back up to the cardiac ICU. He was on what we call full support on VA ECMO, so flows of approximately 5 liters per minute, or maybe even higher in this gentleman with such a large PSA. And then the Impella was maintained at P2 just for a venting strategy. And he had a really, honestly, a marked response to this strategy. He had a lactic acidosis that resolved. This is his urine output the first day was greater than 7 liters after dosing him with some Lasix. But he maintained minimally pulsatile on the VA ECMO. Granted, he was on a LV support as well at P2. He had almost no pulse pressure and had improving NSVT and VT episodes. In the first 24 hours, that was. So here you can see, okay, now this is his invasive hemodynamics from our cardiac ICU. This gap in time was when he was back down in the cath lab being cannulated for ECMO. You can see here when he returned, his pulse pressure, systolic is this top green, diastolic is the bottom green. He had very minimal pulsatility and very low pulse pressure over the course of the first really 36 hours. And into post-op day 2 now, you can see that he regains, in a pretty impressive way, his systolic pulsatility, increasing of his pulse pressure, suggesting myocardial recovery. At this point, his metabolic derangements had resolved, his lactic acidosis had cleared, he was making, effective urine output with the help of some diuretics, and his vasopressors were weaned. So he was actually extubated, still on ECMO, what we call awake-mo or awake ECMO, where he was extubated, still on the circuit on VA support in addition to the Impella, but was neurologically intact, was talking with us and intact cognition, thankfully. At this time, this was again with full VA ECMO and Impella support. You can already see that there's significant recovery of his LV systolic function. Not quite normalization, but marked improvement from the day of cannulation that correlates really nicely with his increase in pulsatility. And here's, your parasternal long axis demonstrating the same. So already, showing significant recovery. On post-op day 2, he went to after, evaluating him clinically, showing his metabolic resolve, all of his derangements had resolved, increased pulsatility, and improved systolic function on his echo. We had weaned the ECMO down to minimal support, approximately 1.5 liters, and showed hemodynamic stability on that. So he went to the OR for decannulation. They do a mild cut down with a direct repair arteriotomy of this, a direct repair of the arteriotomy site, and they place a wound vac, and they placed a drain in this instance in the left groin. We left the Impella in place to further unload the LV around the time of decannulation to provide additional LV unloading and cardiac output. In the subsequent day to that, the Impella was removed at the bedside, and we just deployed those previously placed perclose devices without any issues. Over the subsequent days, he was started on metoprolol, lisinopril, spironolactone. He was in the hospital for a total of 12 days, complicated by a groin infection for which he was placed on antibiotics. That was at the site of his VA ECMO cannulation. But he did remarkably well. He was discharged on day 12. He returned directly home. He just saw us in clinic just over a week ago. He was having a bit of fatigue, but really no other cardiopulmonary symptoms. He had started to engage in cardiac rehab. He's walking a half mile per day. He is planning to go to work next month. And then impressively, he's actively seeking volunteer opportunities to talk about bystander CPR in the setting of some community education. So he's working with some of our EMS and some of our out-of-hospital providers in regards to bystander CPR. This is his echo as of a week ago, showing marked improvement of his LV systolic function on some goal-directed medical therapy, no mechanical complications of his acute rupture or his acute event, nor the Impella or VA cannulation. And has made a really remarkable recovery. So with that, I'll open it up. Questions, comments, concerns about our case that we shared with you today.
Thank you,
This
Tim.
is a fantastic educational case, very complex, and you teach us how to monitor patients after PCI has been done. I mean, under BDMS, we saw a lot of cardiogenic shock, but none of them had been put on PA catheter, Swan-Ganz catheter, no record of these hemodynamics. In this case in Thailand, I might say that definitely the patient would expire in just only 1 or 2 days. What was the real cause after successful PCI and patient went deteriorating within just only 12 hours after procedure? What was the cause?
Yeah, I think it was just he had a marked, ischemic event, and is out of hospital cardiac arrest. He did receive CPR, for 20 minutes or so. So I think there's just a marked stunning in myocardial contractility. And there was probably a sense or a prolonged period where he was fairly compensated, in part because of his age and his prior health. But I think that he, even after the successful PCI, he acutely decompensated in a significant way. And I think, there's reperfusion injury involved. There's a lot of oxidative injury, and this is why people are starting to look at the door to unload strategy for some of these folks with a big anterior STEMI, that you actually up front do an Impella, try to draw down their LVEDP to increase your coronary perfusion. And there's some evidence that affects the penumbra or the peri-infarct zone, that can lessen it to some extent. But mechanically, the PCI was very successful, and I think we avoided a lot of the pitfalls associated with it. But yeah, so I don't have a great answer except for the all of those things that were at play.
And I think, when one looked at the injury current on the initial, what did his post-PCI ECG look like?
Oh, I couldn't tell you with certainty off the top of my head. I did not include it.
I would imagine he is part of the 30 to 35% who have persistent ST segment elevation. So, I would think ineffective reperfusion as the mode in the milieu already of having been hypotensive for a prolonged period, which impacts the microcirculation. The one other interesting point to always remember is when one uses cangrelor, the medications, clopidogrel and prasugrel, can't be given concurrent with the cangrelor because they won't access the receptors, which are blocked. And so typically the easiest thing to do is to use ticagrelor, and it's just an easier transition because you can give that at any time. For the prasugrel and clopidogrel, you have to stop the cangrelor and then administer it. The other thing to remember about ticagrelor is some people crush it and then have the patient swallow it. You want to crush it and leave it as long as you can in the oropharynx, because what you want to do is increase the mucosal absorption in the mouth and not just immediately swallow it. Any other questions?
May I comment on one of your demonstration of the best practice? We have the case that we lost a limb. We lost a limb after ECMO because of the small arterial size. And this is the first time that I see how do you perform the antegrade perfusion to the distal vessel by puncture into the superficial femoral artery. This is the first time. It is very quite interesting because in the past we lost limb after ECMO for 24 hours or 48 hours, and we have to took the ECMO catheter out. This is very nice, very to me best practice.
I think there's variability in the uptake. Some people use it up front. Sometimes it is a bailout strategy if there's demonstrated ischemia. I think the pitfalls are, one is that you ought to use a braided sheath because the regular, our arrow sheaths, our typical femoral sheaths will kink. We often or typically will use a 6 French, and then they have to be, watched very carefully because these external circuits will occlude with some regularity, and so they need to be flushed, extensively every 2 hours. and you got to confirm patency of them, regularly. So they do require some upkeep and close attention, but I think that, there is a trade-off of efficacy and keeping distal perfusion, especially if you anticipate a large cannula and a small artery.
Well,
Thank-
what
I have one. Yeah,
No,
I have
please go
one
ahead.
last comment. Yeah, I have one last comment because in the during PCI, you have two parameters that is the controversy. One is a very low cardiac index, and another one is high cardiac output. And you mentioned about using the fixed method. For me, if you perform thermodilution, you may have cardiac output of only 2 or 2.4. That is will going together with the low CI and may change the strategy inside the cath lab that you should put in either the balloon pump or whatever, because the cardiac output by fixed in cath lab, I'm not so sure. We are well trained for thermodilution much more.
That's a great point. Well, I want to really thank Tim for sharing his cases and experiences with all of you, and it's just been magnificent to have him present the cases, do some of the background, and share some of the data with us. So thanks, Tim.
Thank you, guys.
Thank you, and we wish you the best of luck after fellowship program in the next month.
Yeah,
Thank you.
fantastic, Tim.
Thank you, guys. It's been a
Thank
lot of fun.
you.
I've learned a lot along the way.
Good job, Tim. Great to have had you. Thank you for joining us.
Thank you, and good luck. Bye-bye.